Hi guys, my name is Erica. I'm a student at Middlesex Community College. I am making my last round of videos. I'm going to try to do a video for every lecture just for the last test, just to help us the most if you use these. If not, I love hearing myself talk, so that's okay. Professor Paddock coming at you live. So today is going to be the first lecture, and we're going to be talking about transfusion reactions. So I want to know, why am I giving a blood transfusion? What am I going to assess as the nurse? What should I be looking for as a complication? What are reactions? What do I educate my patient on? What shows me that it's working? And things like that. What do I do before, during, and after giving one? So before we get into any of that, we should know that people who donate blood, so 16 with parent consent, 17 or older are okay, 110 pounds at least. Eat something before. It can take up to an hour long to do the transfusion process. Typically, patients who need blood transfusions either need help maintaining an O2 carrying capacity, they need help restoring any type of blood volume loss, or they need to maintain coagulation properties. That's where we get into like the plasma and the platelets and things like that. Just for baseline knowledge, our normal red blood cell count should be 3.6 to 5.8. Our normal platelet levels should be, it varies from places, about 150 to 450 or 400. Our hemoglobin is 11.3 to 17.3, and our hematocrit is 36 to 52. I just take the low end of the female and the high end of the male when I come up with my levels, just to give me a really good rough around. So before we get into like all the different types of blood we can give somebody, all the nursing knowledge about it, and transfusion reactions, I just want to talk about just who can receive what kind of blood. So I don't know if you can see it, but I just do this little picture, right? So if this is an A blood cell, so A blood cells have A antigens and B antibodies. So we have B antibodies swimming, and we never want to give a B to an A, because see these triangles, they will cause a lock and key scenario with these antibodies in the plasma. If we have a lock and key, then we have a coagulation happening. We never want a lock and key. If we gave AB, we would have a lock and key, so we cannot receive from them. If we gave O, they don't have anything surrounding their blood cell, so it's okay, we could give to them. So we can receive from A and O, and we can donate to AB, because we have this in our plasma, the B, but they have nothing, so we won't have any lock and key with them. So that's just kind of how I look at it. So we're going to say we have an A blood cell, we can receive from A and O, we can donate to A and B. We can donate to A and B because A matches with A, and AB has no antibodies in their plasma, so we don't ever have to worry about a reaction. O has no antigens on their surface, so that's why we can receive from them. Same thing goes with a B. It's literally the same exact thing. So we can receive from B and O, and we can donate to B and AB. So just the two most important things to remember are A, B blood type are the universal recipient. So because they have nothing in their plasma, they will never have a lock and key no matter what type of blood you give them. Versus O is the universal donor. Anyone can get O, whether I have A blood, B blood, AB blood, because O has no antigens on the surface of their red blood cell, they'll never have a cross match with any blood that you give them. So they are the universal donor, AB is the universal recipient. So now that we got those out of the way, I hope that helps someone. If they don't, I'm sorry, I tried my best. Hopefully you can learn it on your own. That's just how I learned it. I have to draw it out on a test and really, basically say, will this cause a lock and key scenario, yes or no? If the answer is yes, then we don't give it. If the answer is no, then we're giving it. So let's talk about the different types of blood we can give a patient. So we stay away from giving patients whole red blood. We don't want to waste. So if I only need red blood cells or I only need platelets, why would I get whole red blood? That's, wasting things. I don't want to overaccumulate things in my blood, things like that. So when I donate blood, it can actually be separated into up to 4 different categories: packed red blood cells, platelets, so on, for donation purposes. So they stopped doing whole blood transfusions unless you're having like a super, traumatic hemorrhage occurring, and they're just putting it in because you're losing everything. So the first one we're going to talk about is a red blood cell. So red blood cells typically should be between 3.6 to 5.8, and we're really looking at the hemoglobin hematocrit with red blood cells. 1 unit of blood given to a patient is about 250 mLs, and it will be equivalent to a fluid volume loss of 500 mLs. We're always going to give this between 2 to 4 hours, no more than 4 hours. We will never hang any blood product longer than 4 hours because that's when bacteria can grow in it. We will never hang more than 2 units without either changing the tubing. So 2 units or 4 hours, we need to change the tubing. We need to, if we have 2 units or more, we are getting a warmer because it puts the patient at risk for hypothermia, which puts them at risk for cardiac dysrhythmias. So typically, if you gave a patient 1 unit of packed red blood cells, we're going to see their hemoglobin increase by 1%, and we're going to see their hematocrit increase by 3%. We give these for patients who maybe have an acute or chronic blood loss and all types of anemias, to include aplastic, B12, sickle cell, or iron deficiency. So who do we give this to, right? Is there standard? So every hospital has a different protocol. Typically, any patient who has less than 6 is automatically getting it. Of course, we're going to find out if they're Jehovah's Witness or any of the different type of beliefs patients may have. If they're refusing it, that's their own choice. They have autonomy to do so. But status quo is if less than 6, they're getting it. Between 10 and 6, typically between 7 and 8, they're most likely getting it because they'll be symptomatic. But every patient's different, and we do patient-centered care. And so anything under 10, they may get one depending on their symptoms. But anything between 10 and 11, they're most likely not getting it. So definitely just assess your patient and see what their symptoms are. They can have difficulty breathing, low O2 stats from that oxygen carrying capacity. They could look pale. So those are all things, maybe a low blood pressure, decreased perfusion when you do capillary refill, things like that for you to assess in your patient. Next, we're going to talk about platelets. So a platelet, 1 unit is equivalent to 50 mLs. We can give up to 4 units between 30 and 60 minutes typically. After we give a patient a unit, we should see their platelet increase at 10,000%. We only want to give a patient platelets if they have a platelet count of 20,000 or 50,000 with an active bleed happening. Typically, we give patients who have maybe hemophilia, a liver disease, because we know our liver houses our platelets. If they have like a thrombocytopenia, purpura, things like that. Next, we're going to talk about albumin. So albumin we can get from the pharmacy. We don't need to do the whole blood bank spiel for it. Definitely see different Jehovah's Witnesses with different practices if this is okay for them or not. So it's an osmotic volume expander. It moves fluid from the intravascular space into the intravascular space. So we're giving this to patients who maybe came to us for burns, shocks, peritonitis, pancreatitis, hypovolemia, things like that. It's a really good volume expander. It's a colloid solution. No ABO really is needed or any type of cross-match, whereas a red blood cell, you need ABO cross-match versus platelets. ABO doesn't matter. Albumin, ABO also doesn't matter. The only thing with albumin, we're going to watch out for fluid overload, so that's going to be JVD, crackles, edema, things like that. And we might need to just slow it down or stop it. That's, provider preference. Next, we have fresh frozen plasma. And so I think of fresh frozen plasma as kind of the glue that helps hold the platelets together. And so we're going to give fresh frozen plasma if the patient's having, just a bleeding problem, maybe a problem in the cascade, things like that, no matter what their platelet counts are. So their platelet counts are they don't matter to us if we're giving fresh frozen plasma. So ABO is needed. So this is super weird, but it helps me remember fresh frozen plasma. That's a 3-word thing. And so we need ABO compatibility. So I think fresh frozen plasma, ABO, needed. RH is irrelevant for these patients, and 1 unit is up to 250 mLs. Fresh frozen plasma is also an isotonic fluid expander, so just look for signs and symptoms of fluid overload with all of our patients, as that is a reaction anyways that we are always going to be looking out for. Cryoprecipitate is basically fresh frozen plasma that has now been thawed. It's typically between 10 and 20 mLs per bag. And it's to control excessive bleeding in patients who have just like super different bleeding cascade issues, like a von Willebrand's, hemophilia kind of things. And those are the bloods that we're going to be talking about and going to be giving. Just like a quick teeny little recap, if a patient is RH negative, they can only receive negative blood. If a patient is RH positive, they can receive positive and negative. So if you had an RH negative mom who's pregnant with a baby that was RH positive, we're going to give them a RhoGAM shot. So if there were ever to be any mixing of the blood that occurs, or typically it doesn't have an issue with the first pregnancy, but the second pregnancy can cause risk to the fetus, we're going to be giving that RhoGAM shot to give them, the antibodies that they need. So let's talk about our patient is coming in for a blood transfusion now. We've cross-matched them. The lab said, okay, everything's great. They had a negative cross-match because remember, positive cross-match means a reaction happens, and we don't want one, so that was negative. We're going to talk to our patient, make sure our patient's on board with it, make sure the provider explained everything to them. We witnessed this consent form occur. The patient has no other questions. Some questions you want to ask them, we want to make sure that they don't have a history of any kind of reactions in the past, and if they do, we're going to pre-medicate them with Tylenol and diphenhydramine, also known as Benadryl, and the Tylenol also acetaminophen. So we're going to do that about 30 minutes before giving it, just to make sure the maximum benefit of the medication. We also, sorry, I'm a little distracted. He just came up here, so cute. So we're going to make sure they don't have a history of transfusion reactions, anything like that, pre-medicate them if they do. Next, we're going to make sure they have 2 IV lines. So we want one for the blood, obviously, and then one for emergency reasons and things like that. So the first one for the blood, we need to make sure it's between 18 and 22 gauge. The higher the gauge, the smaller the needle. So anything above a 20, we do not want, because that can cause lysis of the red blood cell during a transfusion, and we, of course, don't want that. We don't want to give them red blood cells that are broken. We can only use normal saline during a blood transfusion because it's an isotonic solution. We need to use a wide tubing, prime it with the normal saline, and it has a filter in it. That filter, of course, right? Blood, it can clot, so that we want that filter to catch clots. And then I don't want you guys to forget, we're changing this tubing either 4 hours or more than 2 units have been given. So consent signed, all that jazz done. We're going to take a vital signs of our patient before. If it showed our patient had a fever, even a low-grade fever, anything like that, we're waiting and holding the transfusion and contacting the doctor. We're going to verify the blood type, the patient's name, to the doctor's order, to the MRN number, to the patient's blood bank band, and we want to make sure that this blood has not been out longer than 30 minutes. You have a 30-minute time window from when your assisted personnel goes to the blood bank lab, picks it up, and comes back. After you have verified all of that, you're making sure a second nurse now comes and verifies all of that information as well, and they sign as a witness, including the expiration date. Now we're going to get into the transfusion. So our patient, everything we've done, so we just started the transfusion. We never want to just start it wicked fast, right? Because what if a reaction were to happen? So you're going to do it 2 mLs a minute for the first 15 minutes, and it's going to be between 15 to 10 drops per minute. That was a small little discrepancy. One of the PowerPoints said 10. I have written down from a lecture, one of the instructors saying 15, so just 10 to 15, putting that out there. So we're going to do that for the first 15 minutes. We are staying with that patient for the first 15 minutes, and we're monitoring their vital signs every 5 minutes, so 3 times within that 15 minutes. We're going to educate our patient, right? They need to know what they are supposed to report to us: back pain, fever, chills, shortness of breath, itching. Do they feel like they have a rash? Do they feel maybe dizzy, hypotension, throat closing, things like that? We're educating them on what to report. After those 15 minutes have gone by, you've seen maybe no change in vital signs, everything looks good. We're going to leave the room, check on them again in 30 minutes, and then check on them again every hour until the transfusion's done, with a maximum of 4, because then bacterial growth after 4. We're going to monitor for hypothermia if we're giving more than 2 units and do a warmer. And after those 15 minutes, we're switching to the provider's order of how many drops the provider wants of blood per minute. And then lastly, we have our transfusion reactions. So we have an acute hemolytic transfusion reaction. This occurs when there is an ABO incompatibility. So if I have A blood and the lab gave me B, that's not good. So this will typically happen within the first 15 minutes, and it's coagulability of the blood. Our blood, just like basically the A and B, key and lock, coags. I'm going to complain of a fever, shortness of breath, chest pain, back pain. I can be with or without chills, and a big key sign is hemoglobinuria. So that makes sense, right? Our blood is coagulating, and so it can cause acute kidney injury from it clogging in the tubules, and you'll see that with dark urine. And so that's a major indicator. It also puts the patient at risk for DIC, right? Because if all of our blood is doing mini coagulations with this new blood that we got, we're wasting our platelet count, right? That makes sense. So we might need to give that patient platelets or anything to make up for the decrease in platelet count. So what are we going to do? We're going to immediately stop the transfusion. We're going to get completely new tubing, and we're going to keep the line open, just giving them normal saline. We're going to ask them to urinate for us if, they're well enough to and other priorities have gotten out of the way. We want to send their urine down to the lab. We want to send the blood and tubing down to the lab to figure out what went wrong, because I was told that this came to me from the blood bank with a negative cross-match, and clearly they're having a reaction. We want to monitor for renal failure, right, from the acute kidney injury. So maybe they need a diuretic. We're going to be really checking urinary output. Maybe they need a catheter, things like that. Maybe they need a diuretic. So those are all being looked at. Delayed hemolytic reaction can happen a couple months after. And basically the patient is going to complain of just mild jaundice, maybe a low hemoglobin count, fever, things like that. There's really nothing we can do for them, just supportive care and treat their symptoms. Next, we have a febrile non-hemolytic reaction. And so this is for our patients, right? So that's why we're asking them if they have a history, if they have a history of receiving transfusion reactions, because if they do, they might have a hypersensitivity to the plasma protein of a donor. And so they're going to maybe have just the urticaria, pruritus, the small signs and symptoms of maybe an allergic reaction, but nothing like an anaphylactic reaction, right? And so we're going to stop it. We're going to see, did we even pre-medicate this patient? If we did, hopefully we did. We asked them about it before so that we can avoid this, because this is actually one of the most common ones. So the acetaminophen, Benadryl. We never want to give aspirin because it can affect our platelet counts. In a patient who is receiving blood, they probably have poor platelet counts or things going on with their blood. We don't want to disrupt that. And so we're going to call the doctor. The doctor is going to basically be the one to decide, risk versus benefit. If they're having maybe just a rash, they need the blood, so they're probably just going to continue it or things like that, pre-medicate them, so have you. An anaphylactic reaction. So this is the patient that you're going to see who has, an extreme allergy to the donor's plasma proteins. That can have wheezing, angioedema, bronchospasms, hypotension, all over urticaria. You'll know when someone's having an allergic reaction, and so they need epi. So that's going to be our first line emergency drug is epinephrine. Raise the head of the bed. We need to give them an antihistamine, right? Because an anaphylactic reaction is a massive histamine release. We want to stop that transfusion, and we're probably never going to restart it because that is basically just, their airway breathing, not good. That was not a good explanation. I apologize. Just if someone's having an anaphylactic reaction to something, we're never giving it again. So you're stopping it. You're getting new tubing, new everything. Leave the line in place and just put normal saline. Next, we have trolley and taco. These are just abbreviations for an acute lung injury versus circulatory overload. So trolley, basically, it's a reaction where we get so much inflammation, and we know inflammation causes increased permeability. And so increased permeability causes fluid to go, and it's happening in the lungs. So fluid's entering the lungs from that. So capillary leakage, it typically happens 1 to 6 hours after transfusion. Our patients are going to present very hypoxic if they're going to have an O2 sat less than 90 on room air. What kind of crackles are we going to hear? So let's think this through. If we have a patient who is having inflammation in the respiratory system, from some type of injury, we're going to think mucus, right? Like our body just produces mucus to protect ourselves. So you're going to hear coarse, thick, coarse crackles. This patient's probably going to benefit from mucolytics, bronchodilators, chest PT, things like that. So we're also going to be looking for, how do we differentiate this between TACO, which is circulatory overload? We're going to say, do they have JVD? Do we see any pulmonary edema? Do we see any signs and symptoms of heart failure? No. Do we see a fever? Yes. Fever, inflammation go together. So if you see your patient has a fever with difficulty breathing that's not attributed to an anaphylactic reaction, probably trolley. So we're going to get an ABG. We want to look at a chest x-ray. We're, of course, stopping the transfusion. Versus TACO, so this is basically circulatory overload. This is something if you have a patient who has just renal failure, maybe an acute chronic kidney injury, or a patient who has a history of heart failure that you would just be aware of prior to giving the transfusion, you would know about. So we're probably going to say, hey, call down to the blood bank. Can you do 1 unit of blood, split it into 2 so I can give half that unit within 4 hours, right? Because we can only do max 4 hours, and the other half between 4 hours. So you're getting 1 unit over 8 hours, but safely, because these patients probably won't be able to tolerate that amount of fluid at once. So we're going to be looking out for fine crackles, right? Because they have fluid in their lung. Versus trolley, they have mucus in their lungs from the inflammatory reaction. So these patients have fine crackles. We're going to see pulmonary congestion, dyspnea, JVD, hypertension. We're going to slow down the transfusion, right? So first we're probably going to stop it, assess our patient, see what's going on. We're going to check a BNP, and that is basically, it shows the enzymes that your heart gives out when it has to stretch from heart failure. We're going to do a chest x-ray. Maybe they need a diuretic, right? Just to balance them out. So, it's patient-centered care and figuring all of that out. And then lastly, just graft versus host disease has liver dysfunctions. You'll see an increase of liver enzymes. You can have pancytopenia. They're typically diagnosed with a bone marrow biopsy, and gamma radiation is effective in the prevention. And that is all I really have on blood therapy for the nursing care, and then just the roles. So you, the RN, what is my role in blood therapy? I'm going to identify my patient. I'm going to witness consent. I'm going to maintain IV access. I'm going to give the transfusion, educate, monitor, and evaluate. Educate them on what signs and symptoms they need to be reporting to me. If I have an LPN at my disposal, right, what can she do for me? She can check the patient ID, she can monitor the rate, and reinforce any teaching that I've already taught. I have an unlicensed assistive personnel. What can they do? They can monitor vital signs, except I'm doing it for the first 15 minutes, or they can do it, but I'm there. I'm always there for the first 15. And they're transporting the blood for me. Maybe they're running up to the blood lab and getting it, or maybe their patient had a reaction, so they're bringing it to the lab, what have you. And the blood bank is the one typing and cross-matching a positive identification of the patient prior to transporting the blood. And that's what I have. And I'm happy I was able to do this in 25 minutes. The shorter the better, condensed with information, because I know we have so much to learn. So catch me on my next episode, and I'll be covering seizures. Thanks, guys.